Okay, sorry to keep everybody waiting. We're having some technical issues in the back here. So Prof Tan is unable to get through to the air meet, so we're trying to uh, try some other method of getting her in. But in the meantime, we'll be with Dr. Tan. We've got Dr. Tan and Prof Tan. Okay, so Dr. Tan, Hui Siu, we have a question for you here by Dr. Richard Lim. Thank you for the excellent talk. Clinical bioethics should be part of the basic training of all clinicians, but I wonder how much of this happens at an undergraduate level. How can clinicians get more training in clinical bioethics?
Okay. Definitely, I do not think that I had enough when I was undergraduate myself. That graduating from UM, so I think it has kind of changed. I think in recent years, there are more discussions at the bedside or even proper sessions about cases, which is ongoing in the local universities. Definitely, there are more which is being done in overseas like the UK or US if you are graduating from those universities. So I think it is up and coming in terms of professionals, where you are now working. I would suggest that you could always join any of the grand rounds, the ethics grand rounds virtually, or even get a book in on clinical ethics, especially by Johnson or Winslet. And I think that is easily available, that you could get those join us. I think University Malaya has recently had quite a bit of activities and ethics rounds ongoing this year. So you could definitely get yourself into their newsletter and email list there as well.
Thank you so much, Huisu, for that. I think Prof Tan is in now.
Yes, I'm
Are
in
you?
now.
Yay!
Sorry.
Did you have to go outside? Did you have to go outside to get a connection?
Yeah, I think so.
You look like you're in the lovely sunshine. Hopefully, it's not too
I'm on
hot for you.
Merdeka Square.
It's hot. It's 12:38. Gosh. Okay. Well, thank you for coming outside for us. Okay. Thank you, Isu, for that. Let's move on to the next question. Right. From Cindy Teo. For Prof. Tan, with the elderly population patients, they often have multiple comorbidities, making prognostication based on disease trajectory models quite complex.
Yes.
Do you have any tips to help us prognosticate better?
Actually, there still needs to be a lot of work when it comes to prognostication in older people because there's so many variables that are unpredictable. So what we really need to do is to understand what matters most to the older person. So whereas in a younger person, you would look at the disease trajectory and look at how best to maximize the quality of life and also look at how potentially to prolong life. But for older people, what matters most perhaps isn't prolongation of life or maintenance. Maintenance of quality of life is important, but they wouldn't want that in expense of financial catastrophe potentially, and also. What matters most for them is perhaps the opportunity to see their family, go to important family events before they. So that might potentially end up shortening life, but that might not be important for them because they already have had a very long life. So it's complex but not difficult. It just needs a change in mindset. And I think we know a lot more about older people dying than younger people dying. So perhaps one of the things science chooses to do is to ignore wisdom. And that perhaps is something we have to resort to, because we've had we since human history, older people are more likely to die, and they have a lot of wisdom that they could tell us.
Okay, thank you for that, Prof. Tan. Okay, I'm going to switch back to Dr. Tan now. From Dr. Kian Yu Liu, what would be the ethical principles that would suggest the palliative trainee learn, apart from the usual autonomy, beneficence, non-maleficence, and justice, and etc.?
I think the principles still work in most of the situations, that we still look much into best interest, balancing the risks and harms. And I think that itself, there are a lot to actually discuss and to define when it comes to palliative care, because sometimes when it comes to what is best for the patient, from a doctor's point of view, and from what the patients would want, like what Prof. Tan has actually really nicely illustrated in her slides. And I think that itself, it falls into still within that four principles. And I think, I'm on the same page about, like, most of our ill patients and old patients do not actually have a say about what they want in care and where they want to spend the last of their days. And I think that is the main issue we have in Malaysia, where doctors kind of directed most of the care, and actually kind of, in a way, without thinking, they would discuss with the relatives right away rather than thinking what the patients want. So I think it still falls mainly into that four principles, but definitely there are a few more principles that we kind of use when it comes to deciding, whether withholding or withdrawing care. Some of the life-sustaining treatment is killing the patient or just letting the patient go, and we go back to double effect theories, and we look into as well, some of the framework that we use as clinical ethicists include narrative ethics, in terms of, like, knowing where the story comes from, what stories, I mean, in terms of how they make the decisions. And we look a lot also into some of the lenses of some of the minorities, and also the ones which are the marginalized group, and how they view care, and how they view life and death, and dying. So I think that is a wider expanded scope of how we look at some of the cases that we have.
Thank you, Dr. Tan. I remember at the recent pediatric palliative care course, there was the bioethics session. Many of us were so, I mean, I was so angry. A lot of the mothers were quite upset and angry because of the case that they shared that involved a mother and a child. But I think also looking at specific cases, because it's always, it's lots of gray areas, isn't there, in ethics, and discussing them and just looking at many different possibilities in what we face every day. Really interesting. Okay, thank you, Dr. Tan, for that. So back to Prof. Tan. I hope you're okay. I'm worried about you in the sun there.
No, it's
Okay, from Dr. Chi Lung Wan, if hospices do begin to support more elderly with dementia in the community, how would you hope they could help patients and their families? And in turn, what support could they get from the hospital team when difficulty is encountered?
Yeah, dementia care is just ignored. And unfortunately, if the hospice does want to take on dementia care, it is going to need a great deal of funding, because dementia is a very slowly progressing disorder that at the moment is terminal. It's considered a terminal disease, but the terminal phase could actually last quite a long time. So the most important thing in dementia care, we've kind of all agreed, is planning, and that is really not in any way in existence because of the difficulty, the emotive area of actually discussing this while the patient is still able to make their own decisions. It's usually the family members who are actually preventing the discussion. So it is it's a very challenging area, but also the diagnosis could be late. So ultimately, there needs to be a move towards people even making advanced care planning before they get a diagnosis of dementia, so that it doesn't become all a crazy rush to get everything sorted. So advanced care planning, number one. Number two is at the end of life. There's lots of unnecessary interventions being administered simply because people don't understand dementia. So if we could actually help get the hospice care in order to support the family members when we decide not to treat pneumonias. I know that's really difficult. No, pneumonia is a treatable disorder. Yeah, antibiotics can treat it, but so that we keep treating it until the last bullet, and then finally no antibiotic can treat, only we can let go. And that would not be what the older person would want if they really understood the implications of this, because we're using them as culture media for superbugs, which will actually destroy the world. That's not a legacy that any older person would actually want to leave the world with. So we need to really look at those two aspects: planning, and also when not to treat aspect of dementia care. I think that would be the priority.
Thank you, Prof. Tan. I think there was a question following on that. Where would be the best place to start for a quick win? If you want to answer that, and then together with the next question, hang on, from Dr. Richard Lim, you mentioned that it's possible for dementia to follow a trajectory more similar to cancer, but the pursuit of this is not apparent. Can you elaborate?
Okay, so we have already been able to achieve this in a small number of patients which have very good family support, and everybody is singing the same hymn sheet. So what we do is actually maintain a very strict routine, so that everything is automated, and then do everything we can to facilitate any existing function, and also to give them very full lives, so they continue their routines, continue their social interactions, and continue to incorporate them into society. So when the time comes, then there will be a very short, sharp decline. And sometimes we go so fond of them, we don't understand that the short, sharp decline, if we catch it at that point, we stop it at that point, then there will be that we could potentially prolong the terminal phase. So we also need a commitment from family and friends not to actually pursue it when that decline comes, and to allow nature to take its course, really. So then that will actually basically change the traditional dementia trajectory from of a very slow, lingering decline to a short, sharp decline that we see with cancer.
Fantastic, thank you. The next question is from Cindy Teo. If dementia, Dr. Cindy Teo, if dementia is so common and such a common cause of death, should we be screening our population for dementia nationally? I know they do that in the UK. I agree we are missing this diagnosis a lot.
Yeah, that's right. And there is really no commitment to screen for dementia. We really need to change the way we practice medicine, and we also need to change medical education. Today, there is really no point. I know I'm saying this and I might get stones thrown at me. There's probably little point in examining someone's lungs and someone's chest, someone's heart, because whatever you find or whatever you will actually confirm it with an X-ray, and you will believe the X-ray finding or the echo finding or the scan finding more than you will believe this clinical examination finding. But and how often do you now hear a murmur? Now that rheumatic fever is no longer a common disease, how often will you hear a murmur when you listen to someone's chest? So someone's heart. So when you examine an older person, so anyone aged 65 and above, in a hospital ward, you will find cognitive impairment in 1 in 4 of them. And if you do a cognitive screening on someone over the age of 80, you will find cognitive impairment in over 50%. So really, we are failing our patients by forgetting to actually evolve. Medical science has moved to such a point, but the way we teach medicine and the way we practice medicine is still so last century.
Thank you for that, Prof. Tan. Definitely, there's lots that we need to move on and improve more together. Dr. Tan, a definition from Dr. Liang Yik Lim, a definition of medical futility. Is not clear cut. Would you propose that we move away from this term in future education and discussion about appropriate or potentially inappropriate treatment instead?
Hi. So that's a good question, because that's the direction that some of the clinicians, even in the US or the American Thoracic Society, has been moving away from the word futility, because it's actually really hard to define. So that there are definitely sometimes what we do is if we could, as an institution, to actually kind of define what do we say when it's futile. But definitely that there is a new terms coming with a potentially inappropriate treatment, where it is being requested by the family. So there are some of us who feel that sometimes it is a bit vague, when you use a bit gray. So when you say futile, it's kind of a bit more on the firm kind of opinion that the patient would not benefit from that life-saving treatment, or even suffering for more burdens and harms from the treatment. So it is still, I would say it's still not something that we have actually kind of put our foot down about, like whether we should change the terms, but that is something which is ongoing discussion about whether we should change that term. So I think it came from one of the articles, so you can actually check it out at the American Thoracic Society on potentially inappropriate treatment, and they have the whole flow about how do you go about that. Thanks.
Okay, fantastic. So probably a lot more we could learn from from the field of bioethics. Okay, hopefully this is the last question, but it's aimed for you both. Social isolation in older adults. This is from Dr. Malar Kodi Supamutarwayam. Social isolation in older adults is the major issue that we faced during the pandemic. I guess this basically happened mainly due to one size fits all rules. How can we improvise this for the future pandemics, especially for the older adults? Prof. Tan, first.
Very good question. Social isolation as a risk factor, social determinant of health, is actually as high as cigarette smoking when it comes to risk of mortality. So but doctors don't even believe that in this sort of things. They see it as voodoo medicine, you know. So and anything that is not linked to a prescription, etc., is a problem. So actually, we need society to actually have some common sense, and also administrators to have some common sense. Life is what is life worth living, isn't it? Yeah. So if so the risk averseness that we now practice, you know, wearing face masks, avoiding going out, is actually really bad for our health. So this calls for a whole system, whole society approach, whole of government approach. And the future is bright because we've got a new government. So we hope that the new government will have more common sense.
Yes, we're all hoping for that too. Thank you, Prof. Tan. Over to you, Dr. Tan, for any comments on that.
I think nothing much to add. Like it's just common sense. Like when we during COVID, I think even when the non-COVID patients are not getting their families in the wards, and that they were just alone in the ward. I think it doesn't do anyone good at all. So I think it is just being. I would say is I think there are some of us who are taking the easy way out in the hospitals as well, and trying to quote that it might actually cause more harms to the patient by having the COVID there. But most of the time we are I think publics, they know how to think for themselves, and I think they would know what risks they are taking upon themselves, and I think you need to actually kind of listen to what they need and what the patients need as well. And I think to take the easy way out is something that maybe we are just overstretched and we just decided to not do more. But definitely there are many instances that we could have done better. Yes.
Definitely. Lots to learn from. And I think we shouldn't forget as well that despite the pandemic, kind of we're going over the pandemic now, that, our social isolation still exists, and that we should always, check and screen for this, and how we can, how we can approach that together. Fantastic discussion. Thank you so much, Prof. Tan. I want you to get back in, because if I were you, I'd be like sweating like crazy by now. But thank you so much for coming out to be with us. It's been a pleasure to have you both on our
Thank you.
last panel this afternoon. And yes, thank you for being with us today. Thank you so much. We will now,
Thank
hi.
you, Dr. Munira. Bye, Prof. Tan.
Thank you. We
Bye.
will now move on to the closing session. We're a little bit past time, but hopefully everybody can just stay for the final closing remarks. Thank you so much.